going to start. I'm Ira Kirschenbaum. I am the editor-in-chief of the Journal of Orthopaedic Experience and Innovation, Joey, affectionately called. We have a great opportunity tonight to have a guest from across the pond, Chris Miles, who is the lead author on this, what I think is a very important innovation, very important study. We can see that this article got over 1,000 views and 45 PDF downloads, of which Chris promised me he only did about 35 of those downloads personally. I'm not sure that exactly is true. So we're going to start. Chris, I'd just like you to please introduce yourself and tell us where you are, what you're doing, and then I'll ask some more questions about the innovation.
Sure. Well, thank you, Ira. Thank you for having me. I'm looking forward to talking about the paper with you all. My name's Chris Miles. I'm the head of clinical services for Apos Health UK. So, full disclosure, I'm a salaried employee of the product of the company. I'm based in London, so it's 1 a.m. here in the morning. So if I'm looking not so fresh, that'll be why. I'm a physiotherapist by background. So I've worked in both the private and public sector, so for the NHS and private market in various different areas, but mainly focusing in musculoskeletal and orthopedic background. So my role at the moment in Apos Health is to set up the clinical delivery of the treatment in the UK. So we're just in the process of being more and more available within the NHS to patients across the country. We've recently been recommended by NICE, the National Institute of Clinical and Health and Care Excellence, for severe knee arthritis. So it's a real accolade for us, and we're hoping that means that more and more patients will get a chance to experience the product and help as many people as possible. My background, say, is physiotherapist, but I've done a master's in biomechanics. I've done a sports science degree before that, so my brain very much works in a biomechanical fashion. But unfortunately, patients don't always work that way, so it's nice to have kind of the physiotherapy and that experience as well under my belt.
That is great. I'm going to start with bringing up a picture of the product. And I'll say that because I actually, using the American joke, not only am I the hair club president, but I'm also a customer. I actually use this product after my bilateral total knee replacements because my gait was kind of off. I was walking a little bit like an old John Wayne movie or something like that. And I actually used this for about 2 months and significantly improved my gait. I was surprised. When I looked at it, when it was fitted by the physical therapist, I was not a believer, honestly. It just looked a little interesting to me.
You're the only person there, all right.
Yeah, no, it was great. And so I'm going to share the screen, and I'm going to ask you to describe the product here, and how. First of all, just describe it, and then you'll tell us a little bit about the history of how it came about.
Sure. So the product itself is it's a medical device that's in the form of a shoe. So the shoe itself acts as a platform to attach what we call percher pods, so 2 separate pods on each shoe. So a patient would receive a pair of shoes. This is people can see my screen, but the device itself has rails on the bottom, so it allows us to attach these pods individually on the base of the shoe. And what it allows us to do is move the position of the pods very specifically to each patient. So it means we can change the center of pressure throughout the gait cycle very specifically to where the patient we feel needs it. So based on some basic biomechanical principles, but also the symptoms that the patients experience, to try and relieve the symptoms while the patient's wearing the device. The second part is because they're on a convex surface, so the pods aren't completely flat, and we have a variable size and shape of pods. It means that we can change the proprioceptive input going into the joint. So much like a balance board or any kind of other balance device that you would maybe a physical therapist would get a patient to do. You're just doing this on the basis of a shoe. So every time the patient steps, the muscular neuromuscular training is occurring, proprioceptive training is occurring, so that there's some kind of carryover effect as the treatment goes on. So they're the two kind of principles of how the device works. I guess the easiest way I tend to explain it is in the same way we try and unload a joint with maybe things like braces or orthotics. This is doing the same thing, but from the ground upwards. So we're trying to reduce the knee adductor moment, for example, in a medial knee compartment in the OA. We would move the posterior pod more laterally. Okay, so it brings the ground reaction force closer to the center of the knee, and thereby patients tend to say they reduce their symptoms that they're experiencing when they're walking.
So a couple of I'm going to show this gait video. Okay, hopefully it will go. Yes, it's going.
In this video, we will see patients before and after using Apos Health, who go from walking with strain and limitation to moving with ease. This patient is showing classic signs of muscle bracing. She shows very little range of motion in her knees. Her strides are short and her hands are clenched, a sign of pain. About 30 minutes later, she tries her custom calibrated Apos Health device for the first time. Immediately, her muscle bracing is reduced. She is walking faster and her whole body is more comfortable and relaxed. After 5 months of Apos Health, she has adopted better walking patterns, which are noticeable even when she's not wearing the foot-worn device. Comparing all 3 video clips of the patient side by side. Before Apos Health, the first time using Apos Health, and after using Apos Health for 5 months daily, you can see how her natural walking patterns improved. Look at how after 5 months of treatment, her walking pattern has taken on the smooth, coordinated movements learned from the treatment.
All right, I think that was good. So has that been your experience, Chris, concerning over the course of your using this in the clinics?
Yeah, absolutely. I mean, so our bread and butter patient, if you like, is those patients that have tried other therapies. So in the UK, we call it core therapy. So physiotherapy, weight loss, they've been educated on their condition. They may or may not have had some injections or tried braces. That's the point where they enter our therapy, if you like. We'll talk about the inclusion of this study a little bit later, but it tends to be that those patients are, when they see us, in quite a lot of pain. So it's really good in their initial assessment to be able to influence that pain in kind of real time. I was actually, from a personal perspective, I was introduced to this product many years ago from a patient. So a patient actually came in and said to me, what do you think about this? And I didn't know anything about it at the time. But at the time when I was working in the NHS, we were seeing lots and lots of patients with very little kind of scope to see them very often. We didn't have, from a physio perspective, I guess I was a bit frustrated that I couldn't have an impact on these patients that kind of sit in this grey area. We've tried physio, we've tried manual therapy, we've tried other stuff. The only other thing for these guys is then to progress down the line to orthopedic surgeon and more invasive options. And I think this is where Apos Health sits and can really have the biggest impact of those patients that maybe not quite ready for surgery, maybe too young, maybe there's things that we can try and to push back and delay that need for surgery until necessary. So yeah, that is definitely the type of experience that patients tend to have.
Now, the study, you looked at quite a few patients who they were already scheduled to have total. They were told they needed total knees by.
So where they sat in the pathway. So this was commissioned in an NHS knee pain pathway, and the commissioners put a very strict kind of criteria of patients that could come through it. So they met the criteria for surgical referral. So they hadn't necessarily gone to see a surgeon. Some of them had historically, but they would be triaged by an external provider that would measure them against the orthopedic referral criteria. So they would have a obviously severe knee pain, that have grade 3 or 4 arthritis in bi or tri-compartment OA. They've tried core therapies, as I mentioned, so physiotherapy, weight loss. And so the next step for them would be to go and sit in front of the surgeon for sure. Yeah.
That's great. So I'm gonna kind of ask around. I mean, this is really new kind of stuff for us to look at. I'm going to put Andy on the line because I think Andy Wickline has always cutting edge stuff. He's coming out with a paper pretty soon on the role of swelling and pain after knee replacement, which is probably going to change a lot of the way we treat people post-operatively. Now, Andrew, where do you think something like this lands in your, because you're very aggressive in the pre-op area, so tell me, what do you think?
I'm very interested in this. I was just at Duke at the Barron meeting, and Juranic and his partners there showed that these patients with KL4 osteoarthritis, they get them into this very organized PT program, and they were able to show delay as well. And his feeling is that a lot of these patients have those really acute stress responses. So I guess I'm really curious to know what Chris's thoughts are. Being a therapist, he's seen some of these patients in the past. What's the difference? Juranic's saying he's able to get patients delaying from surgery with just regular PT, and he thinks it's just getting patients over that acute inflamed tibia. What do you think the difference is with this product? Is it really just unloading that area as well? Is it just a different way to do it?
Yeah, I think so. From a physiotherapist perspective, obviously exercise is our tool, but the frustrating thing with, certainly from my perspective, the many patients that we see are in too much pain, and to get them through that acute pain phase, if you like, is too large a step for most patients. I think some patients are very good and they could be very committed, but you've got to tell the patient to do exercises that probably puts them in a lot of pain. They're probably not going to do the exercises, so compliance goes out the window. And B, even if they do them, they're doing the exercises in pain, which from a motor learning perspective and retraining muscles is not always that conducive to good motor learning and muscle response. So you want to try and dampen down those pain signals as much as possible. And I say, by just wearing the device, the patient hasn't got to do anything extra in their daily activities. So compliance that we found, even like 2 years down the line, was very high because they're easy to use. And I think from a patient perspective, I think the easier you make it for them, the more likely they're to do it.
Question, Chris, before we get this for a second, how the protocol on how to wear them? You wear them a certain amount per day. That's what I remember. You don't wear all the time everywhere. Yeah.
No, and that is the kind of misconception initially. So we would, again, depending on the patient, and there's a methodology around it. We will start a patient on a very little amount, maybe sort of 20, 30 minutes wearing time a day, and slowly build that up to maybe 1 or 2 hours a day. And we're talking around the house or at work, pottering around, a mixture of time on their feet. They're not kind of doing purposeful walking. So again, it's to try and fit around their normal daily lifestyles rather than making it a chore for them, which I think is a real key factor in, again, getting that compliance up. But what we want to achieve is to actually get the clinical benefit, the symptoms changes, even when they're not wearing the device. And again, 1 or 2 hours use per day seems to be enough to do that.
We have a question from Michael Backus. Mike, you want to unmute and ask your question? Or Michael.
Yeah, I was just curious what the longevity of the shoe and those pods are.
We've Quite a long time. I mean, to put a number on it, we've got patients that have been wearing the device for 7 to 10 years, and the actual, because the parts on the bottom, the pod part, is a removable and changeable part, so we can change that at each follow-up or checkup if we need to. But the actual platform, if you like, lasts many years.
Could you hold that up, the shoe up again?
Yeah, of course. Yeah. I don't know if you can see it on my screen. So this is the kind of more latest version of the shoe. And so I might take myself off of.
Yeah. And the physical therapist, how long does it take to fit a patient?
About 30 to 45 minutes. Again, depending on kind of the experience of that clinician, what the referral type is, if they know what the condition is before they come in. It is really a matter of getting them into the device. We use spatial temporal gait parameters on each patient that comes in, so we have some objective measure that we use to monitor and track that progress over time, and that also feeds into the calibration as well. But yeah, as I was saying, so the actual pods themselves, we can actually remove the pods very quickly and easily, replace them. So if there's any wear, if the patients are wearing them outside and they wear a bit quicker, we can just replace them very simply.
We have another question from Trevor T. You want to unmute and ask your question? All right, I'll ask the question then. How much are the shoes out of pocket?
In the US, I'm not sure. I'm not sure if my colleague might be on. Ganeet Segal is the chief scientific officer and works more closely with the US. I'm not sure if you know that answer. In the UK,
yeah, I do. It's reimbursed in the US by the insurer carrier. It's not self-pay.
It's not self-pay. I had it in a hospital. It ends up costing about, so the physical therapist makes costing somewhere between $3,500 and $4,000 for the whole course of treatment, is my memory from this.
Correct.
And about half of that goes to the physical therapist and half of that goes to the orthopedic surgeon for monitoring the progress. Am I also right about that?
Yes.
Yeah. So, it's about $2,000 a piece to monitor progress for over that time period. And some insurance companies may negotiate it differently over time. I'm sure in UK, it's no cost to anybody, right? It's part of the medicine, the socialized medicine.
Yeah, so in the UK, there's a self-pay market, which again is around about £2,000, and so in the NHS that would be free for the point of service. So the NHS would cover that cost in the projects that we have here.
Charles, Charles Orth, you had a question. You want to ask it or?
Yeah, sure, Ira. Yeah, I was wondering, the shoe looks pretty adaptable to various surfaces, but when you're using the shoe, is it better to start on one surface compared to moving from one surface that's harder to a softer surface?
I guess to get the patient used to wearing the device, I think having kind of one surface is a good idea. But I think in reality, your patients obviously have different surfaces in different parts of their homes, and it changes per room. We don't want to be too restrictive of them for that. So we just say, wear it. Yeah, it works just as well on carpet or laminate or whatever surface that you're on. Again, safety is always a consideration when we're assessing patients anyway. So we're making sure that they're safe, and then you're not going to have any trips or falls when they're doing it.
Yeah, Andy, you had a couple of questions, Dr. Wickline.
I guess it sounds like you use some gait monitoring, and then with experience, I'm guessing you have some sort of protocol. But let's just say the average patient, 85% of patients have medial OA plus or minus patellofemoral OA. So does that mean at the ankle, you're trying to create a valgus load at the ankle to unload that medial side?
Exactly, yeah. So the methodology would kind of dictate for that classic medial patellofemoral pain patient, for example, it will be a lateral configuration of the posterior pod. So that means that during loading response, that when the greatest ground reaction force, the ground reaction force is close to the central of the knee. But also what we didn't talk about is, unlike, let's say, other instruments, braces, orthotics, where it's kind of very static and one-dimensional, we can move the pods actually forward, backwards as well. So from a patellofemoral joint, we would move the posterior pod further forward. So again, from a flexion moment perspective, we're reducing that moment as well. So again, it's very driven by a symptom modification, listening to the patient on every, patients will walk up and down, where's the pain now? And the methodology would guide what pod you're going to move and where you're going to move it. And the idea is to try and reduce those symptoms as much as you can within session.
So I looked at this product, I don't know, maybe a year, 2 years ago, and I see that there's some offerings in New York City, some offerings on the West Coast, and pretty much nowhere else. And then, I just looked up, it looks like you guys have been in existence since 2005. So what's the barrier to adoption? I mean, you're showing results, this delays. You would think insurance companies would want to do this. What's the barrier to adoption?
So I can talk from a UK perspective. The barrier is always, so the NHS is the payer, so they're always going to be the ones that want to make sure that it's cost effective, cost saving to the system, and obviously they want to make sure that it's clinically effective. I just explained to Ira before we joined the call that, say, we've been through a big evaluation process from NICE, the National Institute of Health and Care Excellence, which has just recommended us for severe knee arthritis. But so the NHS as a payer always looks towards such an organisation to evaluate us on our merits, so from a clinical effectiveness and a cost saving perspective. So until we've had that, the adoption has been smaller in the UK and just available in certain pockets. Now we have that. I think the barriers to adoption should come down a little bit. We've proven, I think, over the last 10, 15 years, there's so much research that have gone into the product. People are asking for more RCTs, so there's more RCTs available, more real world studies like this one, proving how the product can work in the real world. I think is quite an important thing. We can do the RCTs, but actually in the NHS, it's a very specific population. Are the patients going to respond in the same way? So I think having more research available to us now is definitely going to hopefully help us with that quest. In the US, I don't know, again, if my colleague Ganeet on the line can give me any bearings on the barriers over there.
Yeah, I think it's pretty much the same barriers across territories. I think adoption is challenging. Any adoption of new technologies and interventions is challenging, but specifically this one, it looks like a shoe the first time you see it, and it's hard to believe that a device that looks like a shoe can actually be significant to the patient and help alleviate pains, improve function. Definitely not something that can address the underlying mechanisms, at least the biomechanical mechanisms of the disease. So the fact that more studies are coming out presenting real-world evidence, such as this one that we present today, helps us build that confidence around the product, and hopefully that, with the support of NICE recommending apples as also a cost-effective product, might help adoption.
Oh, it's great. I'm going to interrupt for a second because we have at a 30-minute point, we often have a advertiser and sponsor, but tonight we have a special one, and this is Orthopaedic Summit. And I'm going to play this video. I think people could see my screen right there. Chris, you see my screen?
Yeah.
I'm going to play this like 2 minutes, put together by myself. So if anyone needs any video editing, it's a side business that I'm running. So I'm going to do this. Here we go. Hello, this is Dr. Ira Kirschenbaum, Ortho Summit 2023, Boston. It is upon us, September 20th to 23rd. This is a must-go-to meeting and probably the best meeting of the year.
This is my 9th year of coming to this orthopedic summit. And I found out that from all the other summits I've been to, this is way better. More CMEs. You can get as much CMEs as you can in one shot. And the lectures are superb, well informed, and it helps me going back home with my practice and a lot of evidence-based medicine. So over the years, learned a lot from this summit.
I really like the research and the detail that they put into the presentations. The faculty is phenomenal. All the staff have been wonderful and great. Very informative, experts in the field, obviously.
What can I say? This is my favorite meeting. It's a meeting you walk around as an industry person and you get to see all of the most incredible faculty here at Ortho Summit. We get quality interactions. We get to see the latest and greatest innovations from industry. And you never without bumping into people that are very hard to access in their busy schedule. So great meeting.
All right, that wasn't so bad, huh? So I am going to see Antonia Chen. You're on the line. Are you available to talk about OSET for a second and your experience?
Absolutely. I'm excited. Thanks for bringing this up. I'm gonna be there as well with you.
Yeah, it's great. Great to have you on board tonight. So we're going to go back to let me ask you a question, Chris. I don't. Are you looking for sites in the U.S. to do these RCTs? I mean, because I think, that would go a long way for payers. And then I'm gonna ask some of the joint people online, Andrew, Antonia, Greg Brown, and others. Is there any value in delaying total joint replacement? And stuff. So first, tell us about potential RCTs.
Again, I may pass this to my colleague Ganeet,
Okay.
as she's more aware of the studies already going on in the US as well. So, Ganeet?
Yeah, happy to. So currently there's one ongoing randomized controlled trial at Geisinger Medical Center. It's a 3-arm study looking at APOS as a conservative intervention for patients with end-stage knee OA. And then also post-op rehabilitation. Those patients are being randomized either to post-op traditional rehabilitation or post-op traditional rehabilitation plus APOS therapy. So all in all, 3 groups of patients. Patients will be followed for 12 months. So that study is ongoing and recruiting. I think in the near future, we just completed a very large-scale randomized controlled trial for patients with chronic low back pain as a second indication. Those are the 2 main randomized controlled trials going on in the US, in addition to the real-world evidence similar to the publication that Chris is presenting today. There's a couple of more going in the US based on our clinical activity. I think those are the main clinical activity in the US today.
Great. So Greg Brown, I think you were very involved with the group that did the clinical practice guidelines for the AAOS, the new ones. Can you give me some comments about where this would possibly land in that arena?
Yeah, I was oversight chair for the third edition of the treatment of osteoarthritis of the knee clinical practice guideline. Um, I would say one of the things we looked at is lateral, shoe wedges, which there wasn't evidence to support. And I don't think that means that this device doesn't work. I think it's a very different approach than just a simple wedge in the shoe. So I'm a little like you, Ira. I'm a owner and a customer. I've got arthritis in both my knees, and the paper I submitted to Joey and you published has my x-rays in it. So I used an unloader brace. It got me through 10 days of a pilgrimage in Japan just as COVID was starting, and I had to come back home early, but I was walking up to 10, 12 miles a day. So with an unloader brace. So I think it certainly has a place. The question is delaying surgery an advantage? I think the answer there is it depends on the individual. I think we look at patient-reported outcome measures, we look at patient satisfaction, we look at pain, but ultimately, I think the bigger issue is that knee and hip arthritis decrease mobility, which ultimately leads to cardiac disease. And so, sitting on the couch to relieve your knee pain or hip pain isn't, it delays surgery, but it's not what's best for the patient. So if this device keeps you mobile and active, then I think it's great, and anything that, it's always better to treat it non-operatively. There's always complications, no matter how good of a surgeon we are. And so, anything I think non-operatively that would advantage, I'd sure like to give it a try. I'm in that, large flyover region and currently in North Dakota. So I'm not expecting you're going to find a therapist here shortly, but I may have to come to you or see you at the next academy meeting or something.
Yeah, come to my clinic. That's all right. So I had the great fortune of training in a small community joint replacement program, the Rothman Institute, and my mentor, Dick Rothman, used to say to a patient, the longer you can wait, you become a better patient, and we become better surgeons, and we have better technology. So I'll pass this over to my, not my co-fellow, but my alumni fellow, Antonia Chen, and say, if you can really delay, what do you think about this whole technology and the idea of putting it into the mainstream of how we look at arthritis and when to cut?
So it's one of those things where the more that we can delay surgery, I think the better it is. But we all know that there's a balance between quality of life and delaying surgery, right? So the first thing that most of my patients mostly say to me is, I wish I'd done this earlier. So there is a fine line between it. But we all know that there's complications and risks to surgery. So I give my patients all the options. I have a lot of patients who come in and they're surprised at the number of options that there are to delay surgery. And they try it all. And once they've tried it all, then they go ahead and proceed with surgery. So we're in the same camp. We were told to delay as long as possible, but they operate on a lot of patients there in the Rothman Institute. So in that small community setting, clearly they subscribe to operating as well too. So I think it's one of those things where it's a delicate balance.
Yeah, I think their community is now the United States. So, so that works out. But I think, Andrew, you dropped in a comment on, I think it was, people pay a lot of money for stem cell, right? And other things. And so, they pay for PRP as much as $1,200 an injection in New York, stem cells $4,000 or $5,000. And, you have to repeat those versus something that, even if it costs $4,000, look at the value proposition. Andrew, So if you were now if you were Geisinger now got merged with Kaiser. So, and Kaiser's goal is, global value-based medicine. So in a value-based world, I think this fits in a little stronger than more biologic injections. What are your thoughts on it?
Well, first, the big payers, we all see this in November, December. You start suddenly seeing, problems with your pre-authorizations, and it's because they're trying to push those patients into the next year because there's a likelihood that those patients will now be on someone else's payroll or payout, or that maybe they've turned 65 now. So I think there would be a very large interest on the part of the payers in this product, because at the end of the day, they do the math, and they just want to delay 6 months. I think 6 months or six and a half months is what I've heard at one of the conferences. So I think the payers have some potential interest. I guess the biggest part for me, if I'm going to sell this, if I'm on a site that has this, is there a money back guarantee, or is there a I'm in, if I spend $4,000 and it doesn't work, do I get half my money back? Or how do you approach those patients to, I don't do stem cells, I don't do PRP. I have trouble selling that to patients when I think the likelihood is not amazingly high. So I guess I'm going to turn that question back around a little bit for Chris and his team. How do you sell this product to patients?
So, in the UK, actually, this project was set up as a risk share agreement. So again, it was we take the risk on these patients that and if they decay and go to surgery within a certain time frame, we give it a percentage back, as you said. So I know that those kind of projects and things have been set up in the past. Again, not sure if that's how it's set up in the US. Going back to the kind of previous points, as you say, injections, bracing and things, certainly in the NHS are used very widely and very kind of frivolously, and actually, again, we look at the NICE guidelines that came out in 2022. They actually kind of changed their terminology in some of these in some of these options. So with injections, for example, we know that the long-term effect of them is relatively poor in terms of the outcomes, and you're having to re-inject, and obviously then there's complications with that if they then go on to surgery. So from a long-term perspective, they're only recommended for a short relief in order to do rehabilitation programs. And again, same for braces. It tends to be, and again, I know people have varied experiences, but the long-term compliance rates with these treatments can sometimes be restrictive. So we're given, this is kind of another string to clinicians' bows, is all right, we can do, I think all treatments, physiotherapy as well, is a delay to the inevitable surgery in some cases. So what we're saying is, well, instead of delaying it maybe 3, 6, 9 months, where we're talking about now delaying it to 2, 3, 4, 5, 6 years, which again, for some patients, that's a real benefit. Personally, they might have things that there's a reason they're not going for surgery. But again, in terms of the health system, delaying surgery by a significant amount can have a huge payback. We've got a growing population. We've got an aging population. So all of these things to manage those cohorts over a longer period of time, hopefully will be positive for all parties.
One of the big thorns in the side of joint replacement surgeons in the United States is obesity.
Mm-hmm.
Okay, for a variety of reasons. Quite a number of studies, we don't have to repeat them all here, on increased surgical site infection and other complications related to, as you get your BMI higher and higher and further higher. But it also, there are some people who just, and the insurance companies, many of them, I think you need a BMI of 12 now to have, you need a BMI of 30 in some companies, 35 in others, 40. And I have some people who I don't think they're ever going to get to a BMI of 40, you know? So if you guys thought of at Apos, really looking at what I call the never jointers, the people who really are just, they have those legs that look like elephantiasis, you know, and they weigh about 270 and they're 5'2", you know, and they have, even if they have just grade 2, you know, KL grade 2, KL grade 3, I think that would be a wonderful study for you guys to look at, you know, people with BMIs of 45, and, you know, because that's a huge population in this country that's getting denied surgery. You know.
I think so. We do have studies on the high BMI patients. Again, Ganeet will be able to shed more light on that. So again, we've showed to be clinically effective in that population. The only caveat, depending on how large, is that there's I guess a limit to the device. The device capabilities, which is only, I think it's again something like 32 stone. I don't know what that converts to, but yeah, Ganeet, is there anything else to add in terms of the high BMI studies that we've done?
Oh, you said it well. There's one study that looked at a specific cohort of patients with knee away and high BMI. High, I mean above 35. But we didn't look at a subset of patients with even higher BMI. So that might be a good idea.
Right. And like I said, sorry.
I was going to say, yeah, like you said, and I think it's the same in the UK, is that there's lots of patients that maybe don't want surgery, or again, for various reasons, you would not like to do surgery on at the moment. Again, too young, you know, high anesthetic risk, other complications. So if there's patients that you're not sure about, I guess they're the ones that, you know, Apos is a good route, because again, there's no risk associated with it.
Andrew, you had another question about the idea of bone loss and pain-free knees.
So you guys have been doing this for 18 years, it looks like. What are your thoughts about patients who begin losing bone? You know, you see them year after year, and now they're extremely varus, and whether or not you get x-rays and geez, doc, my pain isn't that bad, so I really don't want surgery still. But yet, you know, as a surgeon, I'm thinking to myself, you know, now I'm going to have to augment this person. This person's going to need a stem. This is a more challenging case now. What's your experience been with, you know, how do you recommend to these patients, listen, I know your pain's better, but you know, you're creating a problem down the road?
So I think from a clinical perspective, as you say, it's a discussion with the patient based on a variety of things, including their symptoms. But if they have a huge deformity, like you say, then I think that is a discussion that we would be having with the patient. Is actually, it's not just down to your symptoms. I think this is a conversation with the likes of yourselves to shed light on what those implications have. Because again, it's not our bag to get in the way of that. And I think, you know, we're good at what we do, but there comes a line where we need to have that conversation with you guys to guide us on what are the implications if we delay it for. Yes, as you say, we can delay it for the symptoms in that said patient, but if we delay it from a structural perspective, what does that mean for your surgery further down the line? So I think it's a really good question. I think it's not something that we've necessarily had, I can, you know, from my experience, but certainly those that have kind of big, let's say, fixed flexion deformities that, and big, huge varus deformities, I think it's something that and actually valgus is a big one. I've seen patients that respond really well from a symptom perspective, but their valgus is, you know, slowly kind of deteriorating. Those patients I would always refer on for a surgical opinion.
Yeah, that's a great point.
So a surgeon sees the patient with you like every 6 months and gets an x-ray, every year and gets an x-ray. How do you recommend that?
So how it is over here is a very segmented approach in many respects. So patients kind of go through the pathway. So once they leave us, not always do we have them coming back to us, but in those type of scenarios, if you have a good relationship with orthopedic surgeons, I say to go and get their opinion on such a case, they would go and see them. But as I say, for example, in this project, and many respects in how the NHS is set up, is you can only have one treatment at a time. So it tends to be you have to tick this box in order to go and see the surgeon and so on. Having said that, you know, there are ways to, and you know, in certain cases they would still see you, but yeah, it's something that the system has to kind of work out, that kind of approach of a bit more joined up approach rather than working in our silos.
The way it was presented to me when it was brought in to my hospital, and we have a lot of capitated at-risk contracts, was that the surgeon's really in charge. The surgeon refers to the physical therapist. Physical therapist will be evaluating them, but stays within, in the United States, stays within the care of the orthopedic surgeon in the US. So, you know, we do know how to walk and chew gum. And so we're okay with that. We have another question from Triva T. And I was thinking the same one. You know, oh, your video will work. Okay, so I'll help you to ask. So I was thinking the same question. So it's really interesting. Would Apple shoes help younger people like athletes speed up recovery after athletic injuries, ACLs, severe hamstring injuries, ACL, PCLs? You know, variety of things. Let's just focus on athletes.
Yeah,
who are notoriously very compliant with physical therapy. Yeah,
maybe too compliant. No, we've got we have had some experience with athletes and really high-end kind of sportsmen. And as you say, the principles behind the therapy, you know, in terms of manipulating biomechanics and neuromuscular retraining, you know, it just fits, right? In terms of any injury, lots of musculoskeletal conditions, those two things need to be addressed in some form or another. So we have some case studies on kind of accelerated ACL recovery. So again, non-surgical, again, injuries, etc. So again, there is a place for the therapy in those scenarios. Just imagine how much less the patient, from a physiotherapy perspective, how hard I need to work to try and get the patient to do such, you know, exercises. Imagine doing the same exercises but in the device. We can induce so much more kind of training effect in maybe a short space of time. We can challenge the patient a little bit differently. And again, from a rehab perspective, if they've been injured, we can accelerate that rehabilitation in principle. But in terms of a larger scale study or experience, I don't think we have that yet, but I think it is something that we've had done in discussions.
I think it's great. I think I'm going to ask you for some Andy asked about what about the post TKA patient with persistent pain? Any studies looking at that? And that's why I actually use the Apos myself, not because of the pain, because of more of my gait was off, you know. So are you looking at those kind of studies too, post TKA pain?
So we have a study, and Ganeet can add on to this in a second, but we have an RCT looking at post-op response to Apos versus traditional PT alongside traditional PT. So, and what it showed is that Apos enhance that rehabilitation process. So again, you've got the patient back up to full speed, if you like, a lot quicker than the traditional route, which is a really interesting concept. And again, if you think about the bigger pathway for us, if we can delay patients for a significant amount of time, undoubtedly patients are going to need surgery, but then if they picked it up as a rehab tool afterwards to accelerate their rehab further, again, that kind of, in terms of the rehab process as a whole, I think that would really kind of fit in nicely. Have you got anything to add to that, Ganeet?
No, I think that's true. I think the current study that is going on at Geisinger will be a supportive trial for the original one. And there we can probably do a subgroup analysis looking at those with persistent pain post-op. So not everyone has it, like only 20% will suffer from persistent pain. We can identify those 20% and see if there's any additional effect of APOS.
Oh, it's great. So I'm going to begin to wrap this up and just ask Chris or anyone, if anyone has more comments, you could put them in the chat. But Chris, I'd like you to sort of summarize a little bit of what's next for APOS. What's
what's next? I mean, obviously we're very big on collecting data on every patient that we see. So in real world, we're a data-driven company, and we want to continue to gather this real world evidence. Pending so we've just recently been recommended under NICE. So in the UK for sure, the treatment should become more available to patients across the UK. So we're hoping to see that more patients are being able to use the treatment on a larger scale to manage this condition in the long term. So that's what we're hoping to see. I think what we discussed tonight is really helpful, and I think actually where it's positioned in the pathway is key. I think if we can identify those patients better, we can kind of highlight what patients are going to respond well, what ones we need to pass on, what ones aren't going to respond, and the better we get at identifying those patients, the better for everyone.
Well, this has been amazing, amazing advance. I know you guys have been around a long time. Sticking it out on a good device is worth it. Sometimes the world has to catch up to you a little bit, and it works out well. I want to thank you, Chris, for staying up late in the UK.
No problem.
Very good. Really appreciate everyone who's been on tonight. And I'm gonna just say good night, and just remember, everyone, OSET. Use OSET Joey, you get $300 off. I think Kevin said I get 10% of that. I'm not exactly no, I don't get anything of that. Yeah. OSET's truly really a remarkable course. One of the few non-society aligned courses, great for residents, medical students, fellows, senior orthopedics surgeons like myself, junior people like Dr. Andrew Wickline. And even more junior like Bree Paradis and others. So I want to thank everyone tonight, and we'll say good night. All right.